Yeah, this is you can see the mark there and put in a 23 gauge trocar cannula. This is the FAI, one which we failed in a subluxated cataract. Normally I take it around after 2 weeks where we have failed on, I avoid doing it on the same setting, putting in the glue dowel. This is the earlier surgeries which were nowadays what I call it an intrascleral dowel. You can do it without even putting the glue. Well, the master of glue dowel is here with us. Well, we're just showing a small tip. Do a vitrectomy through the incision that we have done. Do the two-hand technique. Here we'll be putting in a foldable lens. You have got the 23 gauge forceps. We can get it from your vitreous surgeons. Well, get it out from one side. Let your assistant hold it, and there are other ways. If we can get it there, you can just hook it around and put it. The second ear is taken off, and that's how you put in the glue dowel. Well, I'll just come to the disasters. Well, you must have seen all these cases where on our good days we do succeed in our cases, but we do end up in problems. Now this is one of the cases. I'll just run it through. Now this was a you can see it's just a 180 degree subluxation. I go ahead with it, do a small nick, start with the rhexis, put in the hook, as my earlier speakers have said. That's what the principle. The second hook, continue with the rhexis, because pull it more towards you, and the rhexis is completed there. And microrhexis forceps definitely is useful. Put in the 3 capsular support, do a hydrodissection, and then put it in the CTR. They are all rightly done. The CTR goes in there, and just aspiration, finish it up. That looks well. I'm just getting ready. I put the lens. This is the multi-piece lens, and look at it. The moment I put it, there has been a rupture in this area. So in this case, well, what to do? The lens is inside. I cannot put a supporting device. What I have done is just loop the hooks with the needle and the suture, a straight needle and the suture. Just the one end of the loop, you can see. The one, if you come to the last part, so we have this, we have pulled it to the one side. So this side, I have just anchored the lens haptic, the multi-piece lens. That's the reason I generally put a multi-piece lens. Then if something goes wrong, you can use the haptic and just anchor it. So the other side was, in the bag, and this side, as the bag is given off here, I used that end and finished off that case. The case has been done almost around 5 years back. The lens is still censored. The fibrosis has taken care of it, and I've escaped with that case. Now this is another disaster that we placed. I think this is, in the case you can see fairly well, once 180 degree plus subluxation. Getting the initial link was tough, because these children, they have the tough capsule. They're getting the first nick, and then there I try to hold with the rhexis forceps, come back, go ahead with the microrhexis forceps. They're trying to do the rhexis. First few steps, go ahead, then more, and then yes, I'm trying to put in the 3. So look at that. I've gone to the periphery. The rhexis margin has gone to the periphery, almost losing it, and then try to go in from the other side. Yes, there are other sides, but we have an eccentric rhexis. Now how to deal with it? Now I just thought that I'll put the Sioni ring, single side Sioni ring, and there sutured the Sioni holes there, the triplet holes, and there slowly put in the Sioni ring. I thought I was successful. Yes, I got it right, because I didn't want to put maneuver it twice, CTR and Sioni, because the rhexis had gone right to the side. Got it in the bag. So this was a simple case, rather a soft cataract. So just use the bimanual. And at this stage, I'm using Dr. Arup's technique of putting a viscoelastic from my left side this is the way, put in viscoelastic from the pushing viscoelastic, and there I just trying to anchor the Sione. The Sione has already been tried, that the sutures are there, I just have to get it. And then most important thing, how much do I pull? Now this is what, as I'm trying to pull, look at it, as I'm trying to center the bag, and there the bag snaps off. So I have nowhere, the Sione is inside, the bag is snapped off. You can see the bag, this part of the Sione is in the bag, and the bag is snapped off from here because you see, just overturned, the rhexis was right to the periphery, so just overturned, just didn't snap off, it just came off, and there is the rhexis marginia. So I have the posterior capsule and the bag and the rhexis marginia, and I have got the Sione eyelet here. So what I decide, I'm looking for a big lens where I'll put it on the ring itself. This would act as a support, but I had a backup of the scale fixated lens. So I just got it to the side, the cortical matter, just so I have this bag, and just put in this big SF5L, and just I put that haptic. You can see this one haptic is here, the other haptic is over the Sione segment that is there, the Sione is, the ring is there, so that is a support here, and then supported it, and this lens, this patient is still doing well and doing fine. So friends, I'll just come to the end of this course.